Hi, everyone. Thanks for joining. We'll get started in a couple minutes here. Hi, everyone. Thanks for joining. We will get started in just a couple minutes. Hi, folks. I'm going to give it one more minute before we get started. All right, welcome everybody to today's webinar, Efficient, Equitable, and Quality Health Systems, Investments in the Structure and Function of Primary Healthcare, hosted by the USAID Integrated Health Program in Nigeria. My name is Stephanie, and I'm a Communications Manager, and I'll be quickly going through a few housekeeping items before we get started. If at any point you're unable to hear our speakers, please make sure that you've connected your audio using the microphone button at the top right-hand corner of the screen. If you keep having issues, please add a comment in the chat and one of our staff will try to assist you. All registered attendees are joining the webinar with their cameras and mics off. Please use the chat to introduce yourself, add any comments, or note your technical issues. If you'd like to come off mute at the end of the webinar during the question and answer session, please note that in the comment box and one of our moderators can grant you access to the microphone. Please note that this webinar is being recorded and the recording will be available after the webinar and sent to your email. It's my pleasure to introduce our moderator for today's session, Dr. Usman Gebi, who's the Deputy Chief of Party for the USAID Integrated Health Program. Dr. Gebi is a trained physician and development expert with 20 years of experience in clinical and program leadership in the international development sector of Nigeria. At Palladium, Gebi co-leads the USAID Integrated Health Program as the Deputy Chief of Party. Gebi served previously as the Chief of Party on a complex PEPFAR-funded project where he provided country and program leadership, managed program and operational budgets, and facilitated relationships with the government of Nigeria and the US government. He is trained in clinical medicine and holds a certificate in epidemiology from the University of Maryland and a certificate in leadership and governance from the Harvard Chan School of Public Health. Without further ado, I'll hand it over to Dr. Gebi.
Thank you very much, Stephanie, and you're all welcome to this exciting occasion where we're going to listen to experiences to be shared by our panel of four lady experts. It's a pleasure to have all of you around. So we're going to, over the next couple of minutes, talk about shared experiences in four key areas, and we're going to have presentations on linking primary healthcare services to secondary health facilities, particularly the experience at special care BB units from one of our operating sites. Secondly, another one on sustainable electrification on primary healthcare facilities. What have we learned? Would again share experiences from someone that's been there to make it happen. And improving gender-based violence services, integration in primary healthcare services, and lastly, enhancing facility and financial management at primary healthcare centers, to hear about the experiences of one of our national team leads, after which we would have a couple of questions and then participation from the audience. It's exciting to have you. So without much ado, we'll proceed to the presentation. Next slide, please. So I will start by introducing one at a time our able presenters. We would first, it's my pleasure and a privilege to introduce Dr. Rejoice Chama, who will be handling our first presentation. Dr. Chama is a University of Maiduguri medical graduate and pediatrician since 2007, specializing in neonatology and providing services at the Maitama District Hospital since 2015. She is the chief consultant, pediatrician, and neonatologist, and manages not only the neonatal unit but mentors residents and other providers and leads the National Neonatal Resuscitation Training. Her commitment to newborn care is further evidenced by her participation in specialized courses and workshops. Additionally, she is a member of the Pediatric Association of Nigeria and the Nigerian Society on Neonatal Medicine. It's my pleasure to call on Dr. Chama to take on the first presentation, Linking PHC Services to Secondary Health Facilities, Experience at her facility. Dr. Chama?
Thank you, Dr. Gabby. Thank you for having me as a guest speaker. I will be taking us quickly through linking primary health care services to hospitals, focus on improving comprehensive newborn care CNC at Maitama District Hospital. Next slide. The goals of comprehensive newborn care CNC include to strengthen and improve comprehensive care for small and sick newborn, to enhance referral process between the hospital and referring primary health care centers, to improve newborn health outcomes. Now, in September 2023, USAID IHP selected Maitama District Hospital as one of the CNC intervention sites. The interventions focused on capacity building, upgrades to the special care baby units, and supply of equipment. Next slide. The aims of the intervention is to strengthen and improve comprehensive care provided to small and sick newborn in the unit, to enhance referral feedback loop between the hospital and the referring PHCs. We can see on the picture, one of the equipment supplied by USAID IHP is solar energy that is already installed and working. Next slide, please. Next slide. The interventions include 6 staffs from the newborn units, doctors and nurses in the neonatal ward were trained on comprehensive newborn care using the national guidelines for CNC. There was also one biomedical engineer that was trained on maintenance and repair of neonatal medical equipment. The said IHP supplies state-of-the-art newborn medical equipment to the SCBU. And as I mentioned in the earlier slide, a solar energy was also supplied, giving alternatives to electricity. Now the newborn unit has constant light supply 24/7. There was also a minor structural renovation of the SCBU unit. Next slide. Now this is a photo slide showing the SCBU of Maitama District Hospital before and after the intervention. On the left side of the slide, we saw a picture with the shelves not covered and the place was crowded. So, but after the intervention, we saw the SCBU has a new face with a brightly beautiful color, baby-friendly color, and the shelves were covered. We can also see that there is proper spacing. Thank you to IHP. Next slide. This is another photo slide showing the hand washing station in the newborn unit, precisely in the outborn area. Before the intervention, the place was not in a good shape, but after the intervention, we saw that the shelves were closed. We now have a brand new hand washing station. And in addition, we can see hanged are the WHO charts for hand washing, as well as waste management for aiding job to the quality improvement team. Next, please. This is a success story, newborn care in action. See a picture of the quality improvement team with a newborn that was 1 month old at the time this picture was taken. The baby was born preterm at 31 weeks gestational age with a birth weight of 1,400 grams. Thanks to comprehensive newborn care intervention at Maitama District Hospital, courtesy of IHP, the baby has gained weight up to 1,740 grams, was weaned off incubator, was comfortable on KMC, and the mother was also comfortable. Baby was discharged strong at a healthy weight. Next, please. The achievements since the CNC intervention, we looked at the statistics in the hospital before and after the intervention. 7 months before the intervention, we look at the discharge, the admissions and the discharge. And we saw that after the intervention, the number of admissions actually increased significantly. So also the number of discharges. We saw that the rate increased from 88% to 95%. All is as a result of the improvement because the capacity of the staffs were built, the equipment that were supplied also make it possible for the newborn to be admitted within a short period of time and were discharged home. That is actually an achievement that we have seen. So there was improved outcome for small and sick newborn following the intervention. Next slide. In conclusion, USAID IHP intervention, CNC intervention at Maitama District Hospital resulted in enhanced care for small and sick newborn through dedicated and committed quality improvement team. It also resulted in decreased need to refer newborns to other facilities for specialized care, such as respiratory support. The new equipment and staff training revolutionized newborn care in Maitama District Hospital. Now there is affordable, high-quality care for small and sick newborn that is accessible at Maitama District Hospital, SCBO, all thanks to the USAID IHP CNC intervention. Next slide. Thank you, thank you, thank you.
Well, thank you so much, Dr. Chama, for such an exciting presentation. And kindly, if you have any questions, put them on the chat box so that we can manage our time efficiently. It's indeed my pleasure to invite our next speaker, who would be sharing with us on sustainable electrification at primary healthcare facilities, a key challenge in many of the facilities we supported. It's my pleasure to introduce our presenter, Dr. Julie Yemi Jonathan, who is a seasoned physician and public health expert, trained at the University of Port Harcourt in Nigeria with over 10 years experience in the field. She's led impactful health programs, notably in the southern part of the country, funded by international funds, USAID and UNITAID. As the country's program manager for We Care Solar, she's been instrumental in the Light Every Birth project, installing over 250 solar suitcases in Kebbi and initiating an all-women team for installations in Bauchi. Her prior roles at the Clinton Health Foundation and FHI 360 highlight her significant contributions to women health and HIV/AIDS services. It's my pleasure to invite Dr. Julie for her presentation. Julie?
Thank you very much, Dr. Gebi. So good afternoon, everyone. Morning and evening, depending where you're listening from. So yes, as Dr. Gebi has said, I'll be talking about Light Every Birth's Kebbi State experience, where we collaborated very closely with the USAID IHP program. Next slide. So at We Care Solar, we envision a world where all women survive childbirth. They also obtain life-saving care, and they give birth with dignity in a well-lit health facility. This we achieve by providing health workers with reliable lighting, mobile communication, and medical devices. So yes, our Light Every Birth initiative that we implemented in Kebbi is an international campaign, majorly focused on providing clean energy to ensure safe childbirth by partnering with various organizations to supply reliable power to public maternal health centers in countries like Nigeria with high maternal mortality and inadequate energy access. It is focused on 3 core belief systems. As you can see in the slide, all women have the right to safe childbirth. Every health facility is entitled, and clean renewable energy is the solution to it. We are currently in 7 countries, and up to date, we have, in fact, this number increases per day, so over 8,600, and then over 36,000 mothers and over 15 million mothers and babies. Next slide, please. So yes, our approach in Kebbi was a systemic approach. What we try to do is that we try to run a state-by-state approach where we identify a state, we saturate that state, and we move on. As soon as we identified Kebbi as one of the states, which is in line with USAID IHP program, we aligned ourselves with the coalition, the PHC Electrification Coalition. And thanks to that coalition, it gave us soft landing, gave us access, also gave us visibility at the national level, state level. Afterwards, we did our entry visit. We actually did a structural, functional, and using data to do a health facility assessment across 600 public health facilities in Kebbi State. Some of these activities were running simultaneously. I think that we should just know this. Afterwards, when we identified 289 facilities that were eligible for our solar suitcase, like you will see in the previous slides, in the next slides, we identified local installers, trained them, and then they began installations. Next slide. So this is the solar suitcase, or the solar system that we installed in over 248 facilities in Kebbi State. It speaks for itself. It comes with medical surgical lights. It also comes with medical appliances like a fetal Doppler and then an infrared thermometer. And then it comes with rechargeable headlamps and even ability to charge phones. Next slide. It is a targeted solar system. It is mainly for the labor ward and also for other relevant rooms to the maternity care. With proper long-term system use and effective monitoring, the solar suitcase may last more than 7 to 10 years. While we attribute sustainability to its own phase, many of our sustainability activities actually commence throughout the life of the program. So for Kebbi, one of the things we did was, of course, to engage stakeholders at different levels to establish clearly defined roles. We identified a biomedical engineer currently with the agency in Kebbi State as our quality control supervisor. We also identified LGA directors to provide coordination across the LGAs, and of course worked with the WDCs for ownership and demand generation. The next we did was to build capacity of local technicians and also healthcare workers on the use, maintenance, and even troubleshooting of the solar suitcases. We also was able to establish a reliable system for identification and resolution of solar suitcase functionality issues, where we integrated the solar suitcase maintenance into the routine planned maintenance program in Kebbi State. Lastly, we are able to reinforce, so we have a remote monitoring system where we do that for life. So as long as the solar suitcase is functional, we have a long-term remote monitoring of the solar suitcase. Next slide. Yes, this slide shows that within 9 months of installation in Kebbi State, the number of deliveries at the health facilities with solar suitcases increased by 26%. It's also important that we note that, of course, it is not, there are other factors from things that USAID IHP did to training skilled birth attendants, to ensuring that access to consumables and everything was available, but we could clearly see that something had happened in that facility. Next slide. And I think I should also say that the impact of the solar suitcase spans beyond just the health sector. Even the educational sector benefits from it, and even the agricultural sector, and even empowerment also benefits from the solar suitcase. So it is, I think I'm excited, and I'm going to quote one of our many healthcare workers that are citing that their capacity to conduct routine and emergency obstetric care, their ability to conduct it without any fear of timing have actually improved. And they've also been able to even provide facility hygiene, provide infection prevention control, and their confidence and motivation have actually improved. So yes, thanks to WeCare Solar and also this robust collaboration with USAID IHP. Thank you very much. Thank you.
Thank you so much, Dr. Julie, for taking us on a fast ride through to show the power of collaboration, capacitation, coordination, and communication. Thank you so much for sharing your experiences with us. It's my pleasure to call on our next presenter who would share her insight on gender-based violence service integration in primary health care. And it is my pleasure to introduce Dr. Ann Parson, an accomplished development and humanitarian AIDS expert with over 2 decades of experience in Africa. She serves as the Senior Technical Advisor for Gender Equity and Social Inclusion at one of our partners, that's WIHA, contributing to the USAID Integrated Health Program. Ann's extensive education includes a PhD in International Leadership and Management and multiple master's degrees. Her career spans leadership roles and significant contribution to program development, evaluation, and policy making, with expertise in various health sectors. It is my pleasure to introduce Anne to share her experiences in terms of GBV service integration. Anne?
Thank you very much, Dr. Gabby. Good afternoon, morning to everyone, wherever you are. I'll be sharing with you an overview of how IHP made a difference in GBV service integration into the primary healthcare system from its inception. As Dr. Gabby mentioned, next slide, please. WIHA played a pivotal role as a lead on integrating gender equity and social inclusion across the program in the 5 supported states and the federal level. WIHA stands for Women Influencing Health, Education and Rule of Law. It is a woman-owned small business with technical expertise in leading projects on health, gender-based violence, agriculture, conservation, and climate change in over 50 countries. And based on our work here in IHP, we incorporated gender and sustainability lens from the onset through stakeholders engagement, building multi-sectoral collaborations, and technical assistance approaches. Next slide. So the need to integrate GBV into IHP stemmed from USAID's requirement, which is based on its policy on gender equality and women's empowerment, aimed at increasing the capacity of women and girls to fully exercise their rights, determine their life outcomes, and assume leadership roles. Next slide. At the inception of the program, WIHA conducted a gender desk review and policy analysis across all the states, and the findings highlighted gender equity and social inclusion issues affecting health, access, and service delivery for women, men, girls, and boys. Some of the findings include these: inadequate capacity of healthcare workers to provide GBV clinical care, poor GBV data reporting in the DHIS, non-existence of functional GBV technical working groups, and also the non-existence of sexual assaults and referral centers. These are just a few of our findings, and they helped us to shape the approaches based on the activities we implemented in the program. Next slide, please. So these are the approaches that we implemented. They are system strengthening, service delivery, capacity building, data documentation and reporting, as well as prevention and mitigation. We collaborated with relevant government ministries and agencies, especially the federal and state ministries of health, women affairs, the primary healthcare development agencies, local CSOs, and other implementing partners funded by USAID in the states where we work. And some of these achievements is based on an effective collaboration that happened while we implemented. We were able to integrate GBV into health policies and guidelines. The GESI and GBV was accepted as a health determinant, and then its inclusion into states' annual operational plans. We supported in developing a national GBV training curriculum and then trained healthcare workers on GBV clinical and non-clinical care. We also contributed to improving GBV data documentation and reporting at the health facilities, leading to harmonizing GBV data tools, its testing on the DHIS2 staging server, and the ongoing review of the NHMIS tools and DHIS2. Based on work with stakeholders, we were able to hold various targeted interactive values clarification sessions, which helped to demystify major socio-cultural norms, values, and beliefs of the communities. And we were able to develop GESI responsive job aids and materials to encourage these practices in health facilities. Next slide, please. So based on our work on data documentation and reporting, here you see the results on GBV data documented from health facilities across the 5 supported states, focusing on the 3 main GBV indicators. That is the number of GBV cases seen, number of post-GBV care received by survivors, and number of referrals that are made. So it is worth noting that just within 2 years of GBV integration into the IHP, we recorded this huge success from almost zero data reporting to this increasing trend in GBV data. Next slide. Next slide, please. All right. So interestingly, based on our efforts on supporting to disaggregate the GBV indicators by type, age, and sex, this pie chart should give us a detailed breakdown of examples of the types of GBV cases seen, the types of post-GBV care received by survivors, and types of referrals that were made as obtained from the GBV addendum of the staging server to the DHIS2. So at a glance, you can see these disaggregates, which will help in future decision making and planning of GBV program. Next slide, please. And here is just a summary of our results over this period. You can see the number of healthcare workers trained, over 3,000 from over 3,000 health facilities. You can see the number of survivors who received post-GBV care and those who were referred for other services such as shelter, protection, and legal services. You also can see the number of gender desk officers instituted into the State Ministry of Health and the gender focal persons in each facility that we supported. We also have numbers of individuals awaiting prosecution across the states we supported as a result of our collaboration with the Ministry of Justice. Thank you so much.
Hey, thank you so much for a wonderful presentation. Dr. Anne. Anne has been able to take us through the experiences along the chain from policy to practice, as well as counting the activities, because it is said that you can only manage what you can count. So we move on to our last presenter of this esteemed panel, Dr. Deborah Joshua, who is the officer in charge of one of our supported primary healthcare services in the Federal Capital Territory. Dr. Deborah Joshua serves as the officer in charge at the Duze Alhaji Primary Healthcare Center In addition to her clinical roles, she also serves as the administrative lead and holds also additionally the position of disease control officer for the Boari Area Council within the FCT, which is the equivalent of a local government. Dr. Joshua is also actively involved in capacity building as a master trainer and mentor, specifically for the facility and financial management training programs. For despite all the inputs that are being received, people have to learn how to manage this effectively. Dr. Deborah?
Good afternoon, Dr. Gabby and everyone, and thank you for having me. So I'll be taking us through the IHP USAID efforts at enhancement of facility and financial management in our primary healthcare facilities. Prior to this intervention, PHCs have been striving to deliver services to the best of their abilities. And with recognition of the fact that primary healthcare is fundamental in achieving the universal health coverage, we have witnessed an increase in support from donors and government. Some of this support is in the area of policy review, where we have to look at the tax shifting and tax sharing. We have witnessed improved funding. There has been improvement in infrastructure, innovation, and maintenance. And there has also been a wide range of competence-based training across reproductive and maternal health, adolescent health, and nutrition. However, one gap that persists for the managerial and financial skill, which is found lacking in most of the officers that are running our primary healthcare facility. This does necessitate the training on facility and financial management. This was in the hope that the officers in charge, we need to be equipped with these skills for effective functioning. And bearing in mind the World Health System during the selection of participants, these included the officers in charge, the World Development Committee chairman, and accounts clerk from these facilities. This, let's go to the next slide, please. Yeah, so these people were trained over a period of 4 days with main focus of equipping them with managerial and financial skill for effective management of multiple sources of income, which we have now witnessed in these facilities. Among the materials that were used is the facility and financial management toolkit, both for the facilitators and the participants. And at the end of the training, each facility was given an operational manual to help them do more on this. And this manual contained theoretical, practical, and generally accepted basis of carrying out management tasks at primary health care. In addition to this was a follow-up on-site mentorship that was over a period of 3 months. This helped in owning the skill for the participants. Next slide. Now, after all this, what have we achieved? We have witnessed an increase, an improvement in these areas. We've seen that the OSC were now able to effectively respond to their roles of planning, organizing, controlling, and leading, among others. There is now efficient engagement of limited staff with the use of duty rosters, schedules, and job description. We now have effective handling of the multiple sources of income to provide drugs and consumables on a regular basis at our facilities. And there has been a strengthened relationship and interaction between the OICs, that's the officer in charges, the World Development Committee as a whole, and the facility staff. We've also seen an improvement in documentation and transparency of services rendered and financial transaction. So in conclusion, I would like to say that the intended results of enhancing the facility and financial management of primary health care facility was achieved as performance have been strengthened and there is better quality service provision. Next slide. Thank you.
Okay, thank you so much, Dr. Deborah, for such a presentation in a summary of such a complex topic. Over the last couple of minutes, we've had what I call almost like biopsy presentations of many facets of PHC revitalization, which the USAID Integrated Health Program, working with other stakeholders, helped to kind of strengthen. I have just looked at the charts. I haven't seen a question. So while
Dr. Gabby, I think you might have muted yourself on accident.
oh, apologies. Yeah, thank you very much for a wonderful presentation of the many elements of the supported PHC revitalization with the experiences that the panelists have shared with us. I've not seen any questions on the chat, so I would proceed with starting the discussion by asking questions to some of the panelists while we await some questions because we still have some good time. Starting with Dr. Ann. What opportunities do you see exists for gender-based violence prevention and care to fit into the broader health sector and new national initiatives? Are there opportunities for collaborations with other gender empowerment programs or work with the Ministry of Women Affairs? Over.
Yes, thank you, Dr. Gabby. Presently, as most of us are aware, GESTI and GBV is still a gray area. It is not yet prioritized in the new SWAP agenda of the Federal Ministry of Health. As such, there's a great need for this to be included. And yes, there are lots of opportunities for collaboration in other gender empowerment programs, such as if the Federal Ministry of Health and Women Affairs will work very closely. There's huge political will, as GBV has attracted interest of the wives of the state governors in the states where we work. GBV is a priority area also for most donors, which encourages collaboration with other implementing partners at national and international levels. The multi-sectoral GBVTWG also can be, further harnessed to get resources that will meet the needs of survivors beyond the health needs, such as health protection, shelter, legal and economic empowerment, which are greatly required by the survivors of GBV. And then lastly, this multi-sectoral harnessing of resources can also help in establishing one-stop shops, such as the sexual assault and referral centers, which are inadequate presently in the country. Thank you.
Thank you so much, Dr. Ann. I will move on to Dr. Chama. So, Dr. Chama, what has been your experience with referrals from primary healthcare centers for newborns? And what have been the challenges faced in the referral process as it currently exists between the hospital and the referring primary healthcare centers? And how has your hospital kind of addressed some of these challenges? Over.
Thank you, Dr. Gabby, for the questions. My experience with the referring PHCs is that our interactions with the PHC staff has improved as a result of the quarterly referral meetings that are being held. And also there is a referral WhatsApp group which was created for each area council. The referral focal persons from each primary health care and the general hospitals, including our own, are members of the group. So now the PHC staffs are more aware of the type of small and sick newborns that they will refer to us due to the improved referral linkage and the awareness that we can handle the cases referred to us. So now we get more referral from the primary health care centers. The challenges we face with this referral are mainly poor condition of transfer, such as no transport. Most of the time, in fact, in all cases, they don't have ambulance. So most of the time, the patients come through public transport. There are no escort staff attending to the patients. There are no first treatment like IV line or oxygen in place. And subsequently, there is delay in time to reach the hospital. Another major challenge we face with the referral process is lack of or inadequately or improperly filled referral letter. So the way we try to address the challenges is by enhancing the referral feedback loop between the hospital and the referring PHC. The referral meeting I mentioned earlier are used to provide feedback to the PHCs on some of these challenges so that they can improve. Also, recently, I think in April, we did an essential newborn care training for 20 high-volume PHCs, and some of the trainees were coming from the referring PHCs. Hopefully, the training will address some of these challenges. I would also want to add that the Maitama District Hospital was given a solar-powered desktop phone by IHP, which is meant to help strengthen the referral feedback loop. There is also a referral directory that was made available to the hospital, which has the contact information of those referring PHCs. These calls are made free to the PHCs. And so every IHP supported PHCs were given printed referral forms, which they are supposed to use. So anytime we have such cases that were referred and with no proper referral processes, we make direct call to the specific hospitals and give them feedback to improve their referral processes. So this is how we address the challenges. Thank you.
Thank you so much for sharing once more your experiences with us. I will move on to ask my next question to Dr. Deborah. This excellent capacity building in terms of financial and facility management has been quite successful. What have been the challenges you have been facing in implementation of this in your facility? And particularly on the issue of transfer of knowledge and practice, how do you handle this in terms of transmission of these capacities from an outgoing officer in charge to an incoming officer in charge at the primary healthcare level? Over.
Thank you for this question. Of course, the FFM is not without its challenges. One of them is the insufficient human power in most of the facility, and mine not excluded. So, and we have a lot of books to be filled for us to get adequate information and to document everything. This lot of books has very few hands to populate them and get them done appropriately. So this is a big challenge. And one of the things we've been doing to combat this challenge is to see how we can break the work down into small bits. Obviously, we are looking at the reports at the end of the month. So why wait to the end of the month? Let's see what you have accomplished in a week. so that if there are gaps, it can quickly be filled. Then we make use of other people who have not been trained in that particular section to offer help by stepping down the training to them, especially the ones that are required to get the job done. Another obvious challenge is the transfer of personnel. People who have been trained have been moved from one facility to another, which is a big challenge. But for us to be able to overcome this and not lose the achievement, and also to be able to continue the knowledge that have been given and the skill, is for the officer in charge that is going to ensure that all that is required to be done under this management tool is included in the handing over notes. The second thing that has helped is keeping the communication line open between the outgoing and the incoming one. This is where I've stopped. If there is, this is the explanation I've given you so far. If there is any challenge, do reach out to me. If it's something we can solve over the phone, fine. Otherwise, we organize a time to meet and look at it together. Then the outgoing officer in charge have to step in as a mentor to the incoming one until he or she is able to take over and continue without much ado in this task. So these are some of the ways we've been managing the challenges we've seen so far. Thank you.
Thank you so much, Dr. Deborah. So we move on. Again, we're managing our time fairly well, and I move on to Dr. Julie. You know, particularly the solar suitcases have generated multiple excitement from many stakeholders. What are the procedures for private facilities or other philanthropic organizations to acquire the We Care solar units for healthcare centers that they would want to support? And what is the vision for We Care solar program in Nigeria after the integrated health program?
Thank you very much, Dr. Gabby. So yes, if you plan to acquire our solar suitcase, I'm the contact person in Nigeria. You can reach out to me and we would start the process immediately. You can also reach out to our contacts on our website and they would also follow through with it. Maybe just to say that, of course, our solar suitcases are specifically for health purposes. And yes, we are welcome to discussing and engaging with private sectors and even philanthropic group on that. The next question you asked was, what is the vision beyond USAID IHP? Yes, I think I should say that currently we are working in Bauchi State and USAID IHP has left Bauchi thanks to their initial engagement and soft landing for us. We're currently working with the government stakeholders, and it's been a smooth ride. What we also do is that we also identify health and energy partners that their projects are in line with our goals and objectives. We partner with them, collaborate with them for amplification of our combined efforts. And that's what we're currently trying to do beyond Bauchi. We're trying to do like a heat map where we're trying to do stakeholder mapping, security mapping, and also project mapping and partner mapping, which will now give us a new direction after the USAID IHP implementation. Thank you.
Thank you very much, Julie. And I'm glad that we still have some time. So I'll quickly go through the panel to see questions from the audience. I can see only one question. There's a comment by Dr. Ambrose Mwezi. Thank you for the wonderful work. Saving sick and small newborns is a challenge in most health facilities. The only question I have is from Dr. Marta Levitt. Marta, I don't know if we still have some time, if you can actually read your question, Powell.
Thank you, everyone, for joining this exciting webinar. I'm Marta Levitt. I'm the Chief of Party for the USAID Integrated Health Program here in Nigeria. I hope you can hear me. Yeah. So anyway, I was wondering if Anne can talk a little bit about sexual harassment at the PHCs among female community health workers and the interventions that IHP worked on to try to alleviate or mitigate such harassment.
All right, thank you very much, Martha. Yes, so over the years of our implementation, we got reports from healthcare workers across the states. Some of these reports bordered on their sexual exploitation and abuse, as well as harassment in the workplace. And at their level, they have a report and redress mechanism, but it seems it hasn't worked, and it doesn't actually cover sexual exploitation, abuse, and harassment. So together with the stakeholders in the states, as well as the health workers, we developed a draft code of conduct, and then this was, through stakeholders engagement. Again, it was shared with the leadership of the ministries of health, as well as the state primary healthcare development agencies. We worked in collaboration with one of USAID's implementing partners also on the health workforce management activity, and we got very good buy-in. As we speak now, this code of conduct has been accepted and launched in Ebonyi, Kebbi, Sokoto, and Bauchi states. So this code of conduct now is an addendum to the state human resources for health policy. So hopefully, maybe of working in the health.
Okay, good.
Thank you.
All right, Anne, thank you so much. And since we have, I think that's the only question we have, so I would quickly, in a minute or less, for all the panelists, starting from Dr. Deborah. So it's like excellent things that have been done with IHP. So what can we share your vision in terms of sustainability? What is your thought towards interventions to sustain continuous funding and sustainability of these interventions in 1 minute or less, starting from Dr. Deborah?
All right, thank you, Dr. Gabi. Sustainability is key in whatever good thing one have done, and with this that IHP you said have achieved, stakeholders engagement, it's something that is crucial in continuing this. We look at government ownership of this intervention. Then we want to look at the support from the local authority that are closest to these facilities for us to be able to continue, especially the mentorship aspect for the continuation of deployment of the acquired skills and sustain the achieved improvements. Thank you.
Okay, thank you, Dr. Deborah. Dr. Chama?
Thank you, Dr. Gabi. As stakeholders at various levels, right from the staffs in the newborn unit, the hospital management board, the health services and environmental secretariat, and the FCT as well, we are all putting effort in place to ensure sustainability of these interventions. So as quality improvement team, we are implementing the action plan we developed at the end of the CNC training with emphasis on regular step-down training to build capacity of those staffs who were not trained during the IHB intervention. So what we do is what the WHO recommend, a low dose, high frequency on the job training for the staffs, which is done regularly. Another effort in place is that we have a regular schedules for service and maintenance of the donated equipment by our trained biomedical engineers. As a quality improvement team, we also serve as advocacy team. We advocate for the Hospital Management Board, the HESC, and the FCTA to scale up training on the CNC to non-IHP supported hospitals in the FCT. I'm glad to announce that the FCT has a pool of trainers on CNC as well as essential newborn care who can be used actually for training health workers in the remaining 9 general hospitals that have not been able to receive the support from the IHP. Thank you.
All right, thank you. We have just about 2 minutes. Dr. Julie, in a minute or less.
Thank you very much. So yes, our program has sustainability in its front burner. And one of the many things that we have done and we would do, or we are doing, is, of course, the solar suitcase in itself is sustainable, is long lasting. Then using local installers, then engaging the quality control supervisor is also part of our sustainability plan. We also plan to train coaching technicians there to troubleshoot and supervise beyond the life of the program because they are government staff. And then also to come up with a sustainability draft, work with relevant technical persons to come up with a sustainability draft where we will input finance on replacements and even procurement of solar panels and solar suitcases if they want to expand. So yeah, these are the things that we already have going, and some we are still, some we have done and some we are yet to do as part of our sustainability plan for Kebbi State. Thank you.
Okay, thank you. And then lastly, Dr. Ann.
All right, thank you. So at the close of our program, IHP worked with stakeholders to develop GST sustainability plans, and some of them include stakeholders engagement at all levels, continuous capacity building and mentoring of healthcare providers to improve the GBV integration and data documentation and reporting. Deliberate inclusion of GST and GBV as a health determinant in the state, develop health development plans and funding through the annual operational plans, and then closing the gap between community sensitization on GBV and prevention, as well as the GBV response in the health facilities. Thank you.
Well, thank you very much, panelists and also participants. We have just come to the end of it, dead on time. We thank you so much for being able to participate in our sharing experiences with all of you, and hoping that all the activities we worked in will go beyond IHP. Thank you so much for your time, and thank you so much. Have a good rest of the day. Bye.
Thanks, everyone. Bye.